Hey everyone, and welcome back to the MediByte channel. I'm your host, and as a healthcare professional, I am absolutely thrilled to guide you through today's explainer, which is all about premature menopause, the clinical roadmap. We're going to break this condition down completely, straight from the clinical data, in a way that's structured, super detailed, and really easy to digest.
So, what happens when the biological clock just stops before age 40? It's a heavy question, right? For the women experiencing this, it can feel like a totally sudden, confusing shift in their health and, honestly, their whole life plan. Today, we're putting on our clinical detective hats to uncover exactly what's going on inside the body, why it happens, and, most importantly, how we can successfully manage it.
Okay, let's dive into our clinical roadmap. We'll start with 1, understanding the condition. Then look at 2, the root causes. After that, we'll hit 3, recognizing the symptoms, 4, the diagnostic process, and finally 5, treatment and long-term health. Section 1, understanding the condition. Let's establish our biological baseline.
All right, getting our clinical vocabulary right from the jump is absolutely crucial. Premature menopause is formally known in the medical world as primary ovarian insufficiency, or sometimes premature ovarian failure. Clinically speaking, it's defined as the permanent end of menstrual periods before a woman hits 40. But what's actually happening biologically? Well, the ovaries essentially just stop releasing eggs on a regular basis. That's ovulation, of course. And because of this, they also stop producing those usual premenopausal levels of reproductive hormones, like estrogen.
The absolute core differentiator here is the timeline. Natural menopause happens on average right around age 51. Premature menopause abruptly shifts that timeline way up to before age 40. Now, hormonally, it looks practically identical to natural menopause. The ovaries are making little to no estrogen, and ovulation has pretty much stopped entirely. But the timing is everything.
Now, as a healthcare professional, I want to heavily emphasize something right here, because this diagnosis is strictly about ovarian function. It absolutely does not mean a woman is aging prematurely. I hear that myth all the time, and it's a really scary one. Actually, the ovaries still contain thousands of eggs. It just means her ovaries aren't functioning normally or responding to the brain signals the way they used to. Her overall biological age, it is not speeding up. Let's clear that up right now.
Section 2, the root causes. Let's uncover those cellular triggers.
So there's actually a pretty wide array of potential triggers here. To wrap our heads around this, remember that eggs live inside these tiny, fluid-filled cavities in the ovaries called follicles. Premature menopause kicks in when there's a drop in the number of these follicles. Maybe they're being destroyed faster, or they're just having a really poor response to the hormones being sent down by the pituitary gland. What causes that? Well, it ranges from autoimmune disorders, where the body literally produces abnormal antibodies that attack its own ovarian tissue, to viral infections like the mumps. It can also be medically induced. Think cancer treatments like chemo and radiation, or obviously surgical removal of the ovaries. Even environmental toxins, particularly tobacco, can trigger the whole shebang.
I definitely want to draw your attention to the genetic side of things too, because genetic factors play a massive role. Sometimes it's just a family history of early menopause, but it can also involve specific sex chromosome abnormalities, like Turner syndrome or Fragile X syndrome. Interestingly, and this is super important clinically, in some rare genetic disorders where a female has a Y chromosome, which normally only occurs in males, not only is premature menopause triggered, but the risk of developing ovarian cancer actually shoots up. So identifying the specific genetic root cause, yeah, highly, highly important.
Section 3, recognizing the symptoms, finding those physical clues. You know, for some women, the only symptom they ever even notice is just that their periods get a bit lighter, irregular, or they just stop altogether. In the clinic, we call that amenorrhea. But a lot of women actually face the exact same physical symptoms you'd see with natural, age-appropriate menopause. We're talking intense hot flashes, night sweats, sudden mood swings, and of course, infertility. These systemic symptoms are basically a direct result of that sudden nosedive in estrogen levels.
What's truly fascinating from a clinical perspective, though, is that those classic menopausal symptoms aren't always the only red flags. Sometimes, the symptoms of the underlying cause are what actually tip doctors off to the bigger picture. For instance, if premature menopause is being driven by an autoimmune process, the patient might present with symptoms of other autoimmune stuff. That could be thyroiditis, vitiligo, or even Addison disease, which is an adrenal insufficiency that can literally be life-threatening if we miss it. The physical symptoms are telling a story that goes way beyond just the ovaries.
Section 4, the diagnostic process. Let's talk about confirming the condition.
So doctors will strongly suspect premature menopause when a woman under 40 comes in with menopausal symptoms or absent periods. The clinical detective work follows a very specific, logical order. Step 1, always a simple pregnancy test, just to rule out the most obvious reason for a missed period. Step 2 is measuring hormone levels in the blood, specifically estrogen and follicle-stimulating hormone, or FSH. A quick pro tip here, these hormone measurements usually need to be repeated weekly for several weeks to get a rock-solid confirmation. And finally, step 3 involves deeper additional testing to hunt down the root cause and check ovarian function, like testing the anti-Müllerian hormone.
Now, once that diagnosis is confirmed, we have to immediately evaluate the patient's long-term health risks. A bone density scan is absolutely critical to check for early signs of osteoporosis, simply because that protective estrogen is gone. We also run blood tests for thyroid and adrenal antibodies to rule out those autoimmune conditions we talked about just a minute ago. Plus, genetic counseling and testing are heavily recommended, especially if the woman is under 35, has a family history of early menopause, or is showing specific cognitive or physical signs.
Section 5. Treatment and long-term health. Managing the future.
Hearing this diagnosis can be incredibly daunting, for sure. But I want to offer some strong clinical reassurance right now. This condition is highly manageable. If a woman doesn't want to become pregnant right away, the absolute gold standard at diagnosis is starting hormone therapy. This is often just birth control pills or menopausal hormone therapy that has both estrogen and a progestin. Moving into the maintenance phase, these treatments are typically taken continuously until about age 51, again, the average age for natural menopause. Essentially, we're just artificially mimicking the body's natural hormone cycle to give her the protection she would have normally had. Then, once she hits 51, doctors will reevaluate if the therapy needs to continue based on her specific individual circumstances.
So why is keeping up this hormone therapy until age 51 absolutely crucial? Well, it's not just about relieving hot flashes. It is about vital organ protection. Without that estrogen therapy until 51, women face significantly higher risks for severe conditions. We're talking osteoporosis, dementia, Parkinson's disease, depression, and coronary artery disease. Estrogen therapy is remarkably effective because our brain and our heart literally have estrogen receptors that rely on this hormone to function at their best. It keeps the bones dense and protects long-term cardiovascular and neurological health. Oh, and as a quick aside, if a woman hasn't had her uterus surgically removed, she absolutely has to take progestin alongside that estrogen to protect against cancer of the uterine lining.
Now, I know what you're thinking. What about fertility? This is obviously a massive concern for many women getting this diagnosis. But here is a genuinely surprising, really hopeful clinical stat for you. Because the ovaries sometimes just randomly start functioning again for brief periods, about 5 to 10% of women with premature menopause eventually become pregnant completely on their own. No fertility treatments whatsoever. Pretty amazing, right?
And for those who don't fall into that 5 to 10% but still deeply want to become pregnant, modern medicine has some incredible solutions. In vitro fertilization, or IVF, using donor eggs is a highly viable path. Eggs from another woman are fertilized in a lab and then implanted directly into the patient's uterus. So, the dream of carrying a child, it is absolutely still a possibility with the right clinical support.
Okay, let's wrap this up with a final thought. The overarching takeaway from our clinical roadmap today is simply this. While it definitely alters biological timelines, premature menopause is highly manageable with the right medical guidance, hormone therapy, and a good support system. But it does leave us with a pretty profound question. As our understanding of genetics and cellular biology gets deeper and deeper, could we one day not just manage this condition, but actually restart the clock? I'll leave you to ponder that. As a healthcare professional from MediByte, my goal is always to empower you with clear scientific knowledge. If you found this explainer helpful, please go ahead and hit that like button, share this with anyone who might benefit from understanding this condition, and definitely make sure to subscribe to the MediByte channel for more deep, evidence-based clinical insights. Thanks so much for learning with me today, and I'll catch you in the next explainer.